It's a pleasure to have you here. I'm Tom Ribeiro, and I will share this webinar on shedding light on a global health threat on Chagas disease, about Chagas disease. And you all know that Chagas disease is a neglected tropical disease that affects almost more than 10 million persons around the world. This is our new numbers. And it's a disease that affects specifically the poor people living in poor houses. And so it's a disease for which we will have few therapeutic options and a lot of need for a better approach to control and to tackle the disease in general. So this is a good opportunity to talk about Chagas disease, and we have a group of persons, of specialists. I'm Tom Ribeiro from the Federal University of Minas Gerais and from the Science Committee of the World Heart Federation. And the main presentations will be made by Bruno Nascimento, also from UFMG, one of the leaders of the RAISE study. And Bruno is from the Internal Medicine Department, School of Medicine, and the Cardiology Service of the Clinical Hospital at Federal University of Minas Gerais, and also from the Madre Teresa Hospital, both in Belo Horizonte, Brazil, and Everton Cousine from the Institute for Health Metrics and Evaluation from the University of Washington, and a researcher of the Global Bundle of Disease Project. And we will have for talking about these new findings and about Chagas disease, Dr. Jonathan Moser, a senior researcher from the Institute of Health Metrics and Evaluation from the University of Washington, Seattle, Bruno Nascimento, and Everton again, Raquel Marcos, Dr. Raquel Marcos from the Latin American Society of Chagas disease from Washington, D.C., U.S., and Dr. Luis Echeverria from Fundación Cardiovascular de Colombia. And we are very pleased to have you all here. And please, Bruno, proceed with your first presentation. And let's go.
Okay, hi everyone. It's a pleasure to be here. I would like to thank the Scientific Committee, the World Heart Federation, and also the IHME for this opportunity. Today here, I'm presenting about the RAISE study, the burden of Chagas disease in the contemporary world. I don't have any conflicts of interest related to this presentation. And as a background, we know that Chagas disease is part of the group of the neglected diseases affecting the heart by the World Health Organization. And we can say that there are different phases, stages of the disease. The acute phase with non-specific symptoms, actually flu-like symptoms or a fever. Then the disease can evolve to the chronic phase, which can be divided into indeterminate, cardiac, digestive, or mixed stages of the disease. In the old estimates, there were about 6 to 7 million people infected in Latin America, and we are going to show the update of these estimates in this presentation. Here is the world map with the prevalence before the new studies and the stages of Chagas disease. And we may ask, what are the bottlenecks in the knowledge about Chagas disease? There are before and still are uncertainties about the prevalence, underestimation and undercoding of mortality associated with Chagas, and also ultimately an unknown burden of disease that we try to address with the RAISE study, which is an international collaboration between the UFMG, World Heart Federation, funded by Novartis, and in a strict collaboration with the IHME Institute in Seattle. The aim is to reassess the global burden of Chagas disease. This is a global aim of the study, performing systematic reviews and advanced modeling to update estimates of prevalence, also estimates related to mortality and the economic impact of Chagas disease, with the key aim to seeking to inform global health policy and bring renewed visibility to this neglected disease of the heart. So here, to fulfill the cycle of research related to Chagas disease, what have we done with the RAISE project? We can show that we made systematic reviews. We re-estimated the number of deaths, recoded deaths related to Chagas disease, modeling the health burden to finalize with the new GBD data, and modeling economic burden related to Chagas disease. So these were our specific aims, 3 groups of meta-analysis: the prevalence of clinical forms, the prevalence of Chagas disease in non-endemic and endemic countries, mortality estimation from the recoding of garbage codes, and also 3 groups of economic analysis about Chagas disease in Brazil and Latin America. So moving to what we have done and published until now. First, we did a systematic review on the economic burden of Chagas disease. After the search, we finalized with 15 papers. And the main findings of this first publication was that first, the cost components that we used from this one to the other economic analysis were inpatient care, exams, surgeries, consultation, drugs, and also implantable devices like ICD and pacemakers. So at first sight, there was a very significant heterogeneity on data about both the methods and the presentation of data related to the economic analysis of Chagas disease. Overall, the mean annual hospital costs varied widely from 25 to 18,000 international dollars per patient. We can see that there's a wide variation, and also this variation is related to the lifetime hospital cost per patient from $209 to up to $14,000 per patient, depending on the setting and depending on the kind of modeling that was used to present, showing that the update of the economic estimate was very important at this point. Also, we published a study about with the Brazilian mortality information system, showing that Chagas disease is basically very underreported and frequently reported as garbage or ill-defined causes of death. So in this analysis, from several years in this nationwide mortality information system in Brazil, we found that the codes that were mostly wrongly not coded, not adequately coded as Chagas disease was mainly unspecific cardiomyopathy, unspecific heart disease, even infectious disease of the lung, and also other kinds of heart failure. Heart failure itself is a garbage code. And after the recoding of these ill-defined causes of death or of garbage codes, we found a 26% increase in the number of deaths related to Chagas disease, showing that this is also a bottleneck for the estimation of the global burden. We did the meta-analysis about the prevalence of Chagas disease clinical forms from the indeterminate form, cardiac form, digestive, and mixed forms, which means digestive plus cardiac forms. Here's the main publications. We got to 73 papers, over 17,000 patients included. And getting to the results, we found a prevalence of the indeterminate form in the overall population of 42%. But when we go to population-based studies, it goes up to 47 to 48%. The prevalence of the indeterminate form was, of course, higher in the population-based studies as compared to the inpatients and outpatient studies. The prevalence of the Chagas chronic cardiomyopathy was around 40%, again, lower in the population-based studies, about 30%. And again, here we can see that there's a bias related to in and outpatients being higher in this population, and about 17% prevalence of the digestive form. We also did a meta-analysis about the prevalence of Chagas disease in Latin American immigrant populations. We got to a final number of 51 reports, and from these reports, we found an overall 3.5% prevalence of Chagas disease in these populations. If we get unselected a group of Latin American immigrant populations, the prevalence was as high as 11%, being 4% in pregnant women and about 0.8 to 1% among blood donors, 2%, 2.5% among patients in Latin America communities living with HIV. Here, we're going to show a little bit of the economic burden of Chagas disease publications. Basically, we did this one about the economic burden in Brazil, a Markov model with 6 health states that we can see here on our right, and a hypothetical cohort of 10,000 patients with 1,000 repetitions to report the average. We got the distribution of the clinical stages based on our meta-analysis, but adjusted for the population age in each group here. And this graph is very interesting and important for the understanding of Chagas disease. We see in green that as the years of infection go by, the indeterminate form goes down with the appearance especially of the cardiac form, but also the mixed form here, a combination of cardiac and digestive forms. So we can appreciate here from the results of this modeling that the years, expected years of life with disability, they are about 20.6 for all patients infected of Chagas disease with all the clinical forms, and we see an alarming 11.8 among patients with the cardiac form. And here's the lifetime costs of patients with in billions, in US dollars, billion here, patients with Chagas disease, 156.53 here for the total cost being mostly related to the direct medical costs, 112 here. And here the annual cost goes up to 11.4 billion US dollars. And now under development, there's our meta-analysis about the prevalence of Chagas disease among the populations at risk, especially in the endemic countries of Latin America. I showed before the non-endemic country estimates about 3.5% among immigrant populations. And here we got to 145 publications. The analysis included 141 of these, over 600,000 patients, being 44,000 with Chagas disease. And the main findings that we can see here, this is unpublished data yet, that we see Bolivia, Paraguay, and Argentina with the highest prevalence rates above 20%, around 5% in Brazil. And when we go to the heat maps, we are still adjusting this. We see that Argentinian populations at risk have prevalence above 25%, being around 5% in Brazil. And the southern Latin America is the GBD region with the highest prevalence, almost 14%. And from this publication, we got to the main paper that we are discussing and proudly presenting here today, that is the updated global, regional, and national burden of Chagas disease, which Everton is going to present from now. Thank you so much.
Thank you, Bruno, and let's go with Everton.
So I'm Everton Cousin. I'm acting assistant professor on the Institute for Health Metrics Evaluation, and today I'll be presenting on behalf of the GBD entities team and the RAISE study this new paper that was just published in the last hour, that is entitled The Global, Regional, and National Burden of Chagas Disease from 1990 to 2023, a systematic analysis for the global burden of disease study. I declare to have no conflicts of interest, and I will go really quickly in this part, as Bruno talked a bit before. So Chagas disease, also known as American trypanosomiasis, is it's caused by infection of the protozoan parasite, the Trypanosoma cruzi, and the transmission modes mainly threatening bugs, also known as kissing bugs. But there are also another modes of transmission, as vertical transmissions, breastfeeding, transfusion or transplant transmission, as well as oral transmission. And as Tom highlighted earlier, Chagas disease disproportionately affects underserved populations. So this results in a considerable health, social, and economic burden. And as we talked before, it has like the two acute and chronic phases, with the acute being very mild or non-specific symptoms, and the chronic being most time indeterminate form, and then have the symptomatic forms relating to cardiovascular disease or digestive forms of the disease. 70% of the individuals are not aware that they have Chagas disease, and less than 10% receive the timely diagnosis that could receive treatment with antiparasitic drugs. And Chagas disease deaths is very often underreported, and updated and robust burden estimates are crucial to effectively inform global strategies for tackling these entities. So our objective of this paper was to do a comprehensive assessment of the global and regional Chagas disease burden and its trends, using the estimates from the Global Burden of Disease, Injuries, and Risk Factor Studies, the GBD 2023. And we produced estimates of mortality and morbidity due to Chagas disease for countries and territories for all years between 1990 and 2023. And for Chagas disease specifically, we created estimates for 20 endemic locations and 32 non-endemic locations. These 32 non-endemic locations are locations where at least 0.1% of the population are from immigrants from Latin America endemic countries. Here I have an overview of our full pipeline for estimating fatal and non-fatal burden. I will not go into every detail, but we can start on the top left. We started with the seroprevalence data that Bruno just described, and we have some data harmonization, age and sex split in those data. Most of the studies are among at-risk populations, so we adjust that for accounting for the population risk adjustment. And then we create birth prevalence using like a first model to estimate the Chagas disease prevalence in women at reproductive age. We also get in the number of pregnant women and the vertical transmission rates to estimate the birth prevalence. And then our main model is this MODEMAR model. This model is a disease modeling meta regression. It's a Bayesian meta regression, full compartmental model, and it has a cascade effect that we first run a global model with all data, and then we run super region, and country-specific and subnational specific models. And those estimates are for only endemic locations. Then we use migration data to create the estimates of Chagas disease prevalence in non-endemic locations. Then we use sequela proportions data to estimate what would be the proportion of each one of the sequelas that we estimate, that I will talk in the next slides. So with that, we have the Chagas disease sequelas prevalence, that we match those sequelas with health states and disability rates associated with each one of the sequelas to create, we then adjust for comorbidity, as people could have experience with other disease as well. And we estimated the YLDs, that is the years lived with disability. That's one part of the DALYs that Bruno mentioned before. So this is our non-fatal pipeline. On the bottom left, we have our fatal pipeline. It's mostly consists on vital registration data that goes through some harmonization and adjustments, including garbage code redistribution. Then we use the cause of death ensemble model with covariates and created the Chagas disease unadjusted deaths. And those unadjusted deaths go to a process called code correct. So we ensure that the sum of all causes that we produce in GBD is equal to the all-cause mortality to get consistency, and also include like the GBD standard life expectancy to create the years of life lost. So that Chagas disease DALYs would be just the sum of the YOLs, the years of life lost, and the YLDs, the years lived with disability. So we have this measure that we both have premature mortality and also morbidity. Here is just a summary of what is the seroprevalence data that we included in this model. As Bruno said, we includes 145 sources from 15 countries, and our case definition was 2 positive tests by a different diagnostic methods, or a single positive test if it was done with either ELISA or ICT. And on this figure, we just have the distribution from 1980 to 2021, or actually the last paper is in 2020. So we can see that there are very few research, studies in the last 10 years. For estimating sequela, so we have, for each sequela, we have a description that's associated with that sequela, and also the disability weight associated that would be included in the wild disease estimation. So we have like mild, moderate, and severe heart failure, mild and moderate chronic degenerative disease, acute Chagas disease, and we also have the asymptomatic Chagas disease, which does not contribute to wild disease, but is important in the prevalence, as we saw in the Bruno's plot, that have a long period of indeterminate form. So here we have prevalence. In this figure on the top, you can see the prevalence rate per 100,000 people, and on the bottom, the prevalence counts in millions. And on the right side of the plot, we have this by GPD region. So in total, we estimated 10.5 million Chagas disease prevalent cases globally in 2023, and this represents a reduction of 16.1% compared to 1990. When we analyze that in age standardized rate, the reduction was of 55%, showing that population growth and population age represent an important factor for Chagas disease. And in terms of death, we estimated more than 8,000 deaths in 2023. And in death count, we have a reduction of 37% compared to 1990. But in age standardized rate, the reduction was as 72.5%. So we are seeing a huge reduction in deaths. In this plot, we're seeing in the x-axis the age group years, and on the y-axis the prevalent in cases. And we have on the top left the global values, and then we have for each one of the endemic regions. And what we can see in this figure is that comparing 1990 to 2023, we are seeing this shift toward older ages in the prevalent cases. And in 1990, the peak was in 30 to 49 years, and a bit over 4 million people lived in those age groups. And now we are seeing that the peak is between 45 to 64 years, and a little bit under 4 million people is living under those ages. In this plot, we have the map of the Chagas disease age standardized daily rate per 100,000 people. On the left pane, we have the age standardized in 1990, and in the right, we can see in 2023. So very clearly, you can see the reduction compared from 1990 to 2023, and we estimated 285,000 DALYs to Chagas disease in 2023, and it was a 42% reduction in counts and 72.8% reduction in age standardized rate. And the locations with the highest age standardized rate was the Goiás state in Brazil, and then Bolivia and Venezuela. Here we are decomposing what is the DALY's contribution from the years of life lost compared to the wild disease for the specific sequelas of Chagas disease. And we can, and on the left, you have the values for 1990, and in the right, you can see for 2023. The plots, they have different Y scales, so it's important to note that the burden is reduced by much, but we can see a similar pattern for both years. And the WILDs is contributed to around 66% of all DALYs in 2023. And among individuals younger than 65 years old, the chronic digestive disorders were the main cause of WILDs, but individuals older than 65 years old, heart failure was the main cause of WILDs. So these estimates of the Chagas disease burden show the decreasing burden from endemic countries from 1999 to 2023. But on the other hand, we are seeing the prevalence increase over time in non-endemic locations, mainly because of the migration. And another important result of that is the shift in the age distribution, highlighting the importance for preparing and adequately funding the health system for caring for older individuals living with advanced sequela, as is that what we'll be seeing in the health systems. And also the continuous refinement of data source in terms of quality and completeness, in addition to adequate encoding and qualification, is crucial for the accuracy of global estimates, which can ultimately drive health and social policies. And finally, despite the global decrease in Chagas disease observed in this period, sustainable funding and support are still needed to advance understanding the clinical aspects of the Chagas disease, as well as optimizing the implementation of effective strategies to prevent transmission and mitigate the burden of its sequela and enhance our awareness of its condition. I'd like to acknowledge that this is a huge effort in collaboration from the IHME and these teams and the RAISE study team, and also acknowledge the funding from the Gates Foundation, World Heart Federation, and Novartis Pharma. Thank you so much.
Thank you both, Everton and Bruno, and this is very, very interesting. And Everton, we have been working together in the last 3 to 4 years about this, and you summarized it very well on how the estimates of the burden of Chagas disease was made. But please, can you go further in some of the challenge you had in quantifying the burden of disease, especially the Chagas cardiomyopathy? What are the main topics for you, the main challenges in this field?
Yeah, thanks, Tom. I think we have like 3 main challenges in estimating that I'll highlight. The first one, as you presented and Bruno showed, most of these studies are conducted among population at risk, with very endemic populations, rural areas. And it's quite challenging to translate that into national or states representative estimates and have what would be the overall burden of estimates in those locations. So that's the first challenge that we started. The second one is many people are not aware that they have disease, and this disease could last like for decades in the indeterminate form with not any symptom, and to identify the morbidity associated with that and like treat those people and estimate morbidity like cardiomyopathy and other forms. It's quite challenging to have that lag between time of infection to actually the symptoms onset. And the third thing that I would highlight is regarding deaths. We know that coding deaths is quite challenging if like people do not are aware that they have the disease. How would the physician say that in the declaration of death? And so and we are seeing a lot of difference between coding deaths between all the different locations in endemic countries and even in non-endemic countries, like how if they are coding that deaths as Chagas disease or just other forms of many times other cardiovascular disease that's not directly related to Chagas. So estimating the deaths is another challenge that we face in this. We use like garbage code redistribution to try to address a bit of that, but yeah, it's still like better standardized coding practice across locations would be very helpful for that.
Only as a something in addition to the question, do you think that the very low number of deaths that we report in some countries with some million of hundreds of thousands of millions of infected persons can be related to this underreporting of Chagas, and that maybe the number of deaths, the real number of deaths could be higher or not?
Yes, yeah, we have discussed this several times. for us, we consider Brazil as like our gold standard, and we have many reported deaths. But as Bruno showed in one of these studies, even in Brazil, when we have a good coding practice for those deaths, we are seeing a lot of underreporting, especially difference across different states. And if you go to other countries, and we compare like the number of cases to the number of deaths reported, it seems that we are missing a lot of deaths in those locations. So I think it's one area that we could improve our models a bit. But for that, we need like training people to address that better.
Yeah, thank you so much, Everton. And continuing in the IHME team, and we'd like to thank John Moses for leading all this activity from your side. And as a senior researcher of the GBD group, can you give us some further insight on the data behind the GBD estimates? Well, only a parenthesis. For many persons external to the GBD team, it seems like sometimes like a magic, and so we know there is a lot of science on it. So can you give further insights about key steps on these estimations based in data sources?
Yeah, thanks, Tom. I'd be happy to, and thanks to both all of our collaborators at IHME, to the RAISE team, and to the large group of multinational collaborators who are involved in producing these estimates and working on this manuscript. So I think we've talked, first maybe to talk about mortality data. We've talked a lot about the cause of death data that we're using from vital registration systems and the challenges associated with that. And I think both Bruno and Everton have talked about garbage codes. So garbage codes being when a cause of death is attributed to something like unspecified arrhythmia or cardiac arrest, or something that doesn't really precisely tell you why that person died. And so we do use this process called garbage code redistribution, where we have within the global burden of disease study some links to say, well, if this is the garbage code, if this is the ill-defined cause of death, what are the plausible things that it might actually have been? And then those deaths are redistributed proportionally to each of those different causes based on the likelihood that it actually truly was one of those underlying deaths. But the second thing that we've talked about that I think is a little bit different is misclassification, which is to say that it's not that the death due to Chagas disease is coded as a garbage code, but rather that it's coded to another, true underlying cause of death. And those are harder to get at. And that's where I think a lot of the work that the RAISE study has done has really been useful, to look at some of these high quality data sets and to think about how do we link together data from hospitals and cause of death systems to really try to understand the full scope of the disease. But it is important to keep in mind that a lot of things have to go right for a cause of death to really be coded accurately. The person has to be diagnosed during their life with Chagas disease. The cause of death needs to be accurately recorded as due to Chagas disease, and then that needs to go into a vital registration system that can accurately capture and summarize the deaths. And so I think your point earlier about the risk of underestimation of mortality is very accurate. We then use, as Everton mentioned, we bring that information together along with some covariates to estimate mortality in this ensemble modeling approach called the cause of death ensemble model, that tries to integrate all of these data sources after we've done these adjustments for garbage codes, et cetera, to produce these estimates of mortality. And then for prevalence in endemic countries, as Everton has mentioned, we updated a systematic review of seroprevalence surveys, yielding 145 surveys across 15 countries. And these are all essentially almost all within populations at risk, requiring this population at risk adjustment. So I think a couple of things there. One is that our prevalence estimates are coming from seroprevalence, which gives us I think a better idea of sort of how incidence has transformed into seroprevalence over time. And it's a way for us to try to work around what we all know is a big challenge of underreporting of incident cases within many reporting systems. The challenge there, though, as many have mentioned, is that we have to adjust that for the population at risk. And it is very hard to understand in the population at risk. We're leveraging estimates from WHO and from PAHO. But truly, especially in places where intervention efforts have really decreased the number of vectorial cases over time, it's very difficult to understand how that population at risk has been evolving and changing truly. And so I think more research is definitely needed in that area. And then the last I would say is that the prevalence in non-endemic locations we're estimating based on migration patterns, as Everton mentioned. And that's partly because, as Bruno mentioned, a lot of the data that's available on directly measuring the prevalence amongst population or the population that has migrated from endemic countries in non-endemic locations is somewhat heterogeneous and sparse. And it's very difficult because of a lack of access to care and a lack of access to diagnostic services. And in many non-endemic countries, a lack of awareness about the disease to get a true estimate of how many people have Chagas disease and living in non-endemic countries. And so I think that continues to be a challenge and one that's really worthy of further investment as we, in this paper, highlight that we believe that the number of cases in non-endemic locations is continuing to increase, highlighting the role of Chagas as a global health problem.
Oh, thank you. And I think that we can continue in this topic of Chagas disease in non-endemic countries, because it was one of the main findings of the study. We have a very steep decrease of number of cases in endemic countries, although it's still it's very, very common and very, very important. But we have an increase of number of cases and deaths in non-endemic countries. And I would like to call Raquel Marcos from the US, that leads Latin American coalition for Chagas disease, to talk with us about some difficulties that migrant populations might face in terms of being diagnosed with Chagas or Chagas disease or Chagas cardiomyopathy, and assessing care for it. Raquel, are you there?
I just wanted to say that was a beautiful discussion of the data that you generated. It's absolutely fantastic. But one of the comments that you made, I just wanted to reiterate, which is that I think the data in the United States is a little bit of a mess, because what we can see from some of the database studies that have been done before is that, for example, I think there was one done from a Medicare data set in which only 70% of the participants were identified as being Latin American. And while I think we have an unknown quantity of Chagas disease that's domestically acquired, the likelihood that only 70% of folks were Latin American in origin is it's really very unlikely. So we do have probably overdiagnosis in some data sets. Our biggest problem is massive underdiagnosis, as you alluded to, and I think everybody on the call knows. So this is a huge problem that we've been facing. The reason that I got started doing this work is because you couldn't find a physician who actually had been told that they might see Chagas disease in the United States. And often that's what they say, is we don't see it here. So the patient, if they're lucky enough to actually understand that they're at risk for Chagas disease, goes looking for medical care and can't find it because they just meet a blank stare. Another huge issue is that we have a lot of immigrants from endemic countries who have never heard of Chagas disease. If you talk to them about the vector, they'll say, yes, I lived in a house with a chinche or a vinchuca or whatever the name of the bug is from the country that they came from, but they won't have awareness of Chagas disease. And with the exception of the Bolivian immigrant community with which I work a great deal, they then don't necessarily have a huge incentive to get tested because they're just so unaware of what the disease actually means. Then we have the issue of the cost of testing, which is prohibitively high for the vast majority of individuals who are at risk for Chagas disease. As everybody knows, they come from resource-poor environments in endemic countries, and they live in resource-poor environments in the United States. There's language barriers, there's low healthcare literacy. Now there is tremendous hostility towards this community in the United States, which is really hampering our efforts to raise more awareness. We have to do so with great trepidation now because we don't want to call undue attention to events. With that as a backdrop, and none of that has changed massively since I started doing this work in 2012, it is certainly true that we have more and more people who join our meetings about Chagas disease to talk about Chagas disease as a problem in the United States, more and more interest, in sort of select areas of doing testing. And, I think we all are relatively proud of what we've been able to achieve. Certainly in DC, we've now been able to get people to start doing prenatal testing at high-risk clinics. The hospital system where I work actually routinely tests for Chagas disease in individuals from endemic countries with cardiac disease. Our screening efforts continue to go on. And there are other areas in the country, I think, that are doing a really good job. But we still are faced with, I'll give a talk, and routinely at the end of a talk, to medical audience, I will have somebody come up to me and say, well, I've never seen a case. And I ask them, have you seen someone from Latin America? And they say yes. And I said, well, you've probably just missed it. And that happens all the time. So I don't know if I'm rambling, Tom, if you want to redirect me to a specific question, but those were the comments that I had off the bat.
I think you told us something about the access to testing and about medication. We have the specific medication for treating those early cases, the benzonidazole, and also the treatment of heart disease, pacemakers, ICDs, and drugs. What is the situation of access to treatment in Chagas disease?
Yeah, so that's a great question also. So we are fortunate now that both benzonidazole and nifurtimox are FDA approved, yet we still face sporadic, very significant barriers to getting this medication, either because sporadically Exeltis, which brings in the drug from Argentina, there'll be some sort of major supply chain issue. And so there have been times when we've not been able to get treatment, including for folks who've had, reactivation disease. So it's really very clinically significant. Right now, we've just had an era where we've been unable to get medication. And the process, unfortunately, is still kind of fraught. I mean, we're incredibly grateful to Exeltis for bringing the medication to the United States, but it's very cumbersome. And we've had occasions where we've not been able to get medication for acutely ill people, and that's a real problem. In terms of access to care for the rest of the significant healthcare burdens for individuals with Chagas cardiomyopathy, it's one of the problems that we face, and I'm embarrassed to say I don't know enough about some of the healthcare systems in other countries to be able to say how common they are, is that every state has its own healthcare program for the individuals who are mostly at risk. So you can be in a state like Massachusetts or California and be able to access, because of their virtually healthcare. In any event, so in some states, individuals who are stricken with Chagas cardiomyopathy can get very, very advanced care. Even in those cases, in those states where there are health insurance programs that provide really quality care to individuals in this demographic, it is rare that you will be able to get advanced heart failure therapy. So you might be able to get a defibrillator or a pacemaker and guideline-directed medical therapy, but the likelihood for LVAD or transplant is very small. Where I work in 3 states. I work in Virginia, Washington, D.C., and Maryland, and each state has a different set of insurance programs for the citizens. And at this point, the one that did have a program for which individuals who are here without documents, which is the bulk of our practice, they're getting rid of that program just because of the politics now, which means that basically no one who I see in that particular demographic is eligible for advanced therapies. If someone is fortunate enough to have come here with and is eligible for insurance, then it's a different story. Then we've transplanted, I think, close to 10 people in the 10 years that I've been doing this work, and have had some others with LVADs. And that's at one hospital system in DC. And then in Virginia, we've had probably the same amount. And folks can get epicardial VT ablations and things like that. But it all hinges on whether or not they're insured. And as we know, most of the folks who are struggling with this illness are not. So that's a real problem, and it's not going to get fixed, certainly anytime in the next 3 years, for sure.
Yes, thank you. This is exactly what we are thinking. And now we should move for what are the situation of the cardiac care for Chagas patients in Latin America. And we have here Luis Eduardo Echeverria from Colombia. Then help us to say something about this. There is a question on the chat about the number of Chagas patients that undergo heart transplantation, that we know there is a very small number considering the number in need. But please tell me a little more about treating heart failure of Chagas cardiomyopathy in a middle-income country like Colombia, that I think is very similar to my country, Brazil.
No, in our center, approximately 20% of the patients presenting with heart failure in our institution are identified as having Chagas cardiomyopathy. And it's our third leading cause of heart failure, surpassed only by ischemic and idiopathic etiologies. However, this was not always the case in my center. 10 years or 20 years ago, is not significant the number of patients of Chagas in our institution, but it's not true, because the reason is because we don't perform at that time serology in all the patients. Right now, it's mandatory to a patient with heart failure or a cardiomyopathy in our center to perform the test. And this increases the number of the patients that we are able to identify with Chagas cardiomyopathy. And you took a specific point of heart transplant. And talking about heart transplant, it's the third cause of heart failure in our center, but it's the first etiology that we would need that heart transplant, because the behavior of the disease is completely different. Is the pump failure is different. There is a more sudden death in this case, and even more stroke in this population, and the behavior is more. There are more complications in this in the patient with Chagas cardiomyopathy than the other, and that is why it's our first cause of heart transplant in our center. But it's not the same reality in my center and the other ones in Colombia. The most of them have less than 5% of the patients with Chagas cardiomyopathy, and in many cases, there are not the number of patients that we have in this specific region, but the most of the causes is because they don't perform the test in every patient. And in Latin America, and I believe that in the United States too, you have to perform the test in all the patients that have heart failure, in the same way that you perform a test for thyroids and another cause of heart failure.
Yes. And about the treatment, you were one of the leading authors of a recent published paper, the Parachute HF. And this is a trial that showed the benefit of sacubitril valsartan in Chagas cardiomyopathy, and was published recently. It was presented recently at the European Society of Cardiology. Can you help us to say what are the meaning of these results for treating Chagas disease?
Okay, that's true. That is an incredible trial for us, for the people or the doctor working with Chagas, because Parachute trial is the first large-scale study specifically designed to evaluate the role of the conventional heart failure therapy in patients with Chagas cardiomyopathy. In this trial, sacubitril valsartan was compared with enalapril at guideline-recommended target doses. The primary analysis used a win radio approach incorporating mortality and heart failure hospitalization and reduction of natriuretic peptide. This is a composite outcomes that try to use first mortality mortality was not significant, then one heart failure hospitalization, and then it's not significant. You use the decrease of natriuretic peptides. The win radio favored sacubitril valsartan, although the observed benefit was not in mortality and not in heart failure hospitalization. Is mainly driven for the decrease of natriuretic peptide, but it was incredible difference between enalapril and sacubitril valsartan. We know that the study was on the power to have the only the one outcome, mortality or heart failure hospitalization. You have to remember that pivotal trial was paradigm used 8,000 or more than 8,000 patients. In this case, is less than 2,000 patients we have in this study. But truly make this study important is not the result, is that represent the largest cohort of patients with Chagas heart failure treated with contemporary guideline-directed medical therapy. It provides new insights into the clinical behavior of this population and might help us to identify which patients are at the higher risk for severe outcomes such as sudden death or the stroke. And there are many information what we are able to extract to this trial to understand better the disease.
Yes, we are sure that there are very, very few clinical trials in Chagas disease. What is related to this neglected aspect of the disease, it's very important to have clinical trials for heart failure, that it's probably one of the most lethal cause of heart failure we know. So I'm very happy that you have conducted this and we have these results now. And our final question for Bruno Nascimento. We have been working with the RAISE study, and we have these new estimates. And what would be the impact of these new findings to the clinical practice, to practitioners, to policymakers, and even patients? What is your opinion about this?
Well, thank you so much, Tom. It's a broad but very important question. And when we have a new set of data and new estimates like this, the question is, what's going to be the call for action? What are we going to do from today on? At the first point, one of the most important points is related to the reduction in disease prevalence, which was driven by several aspects, but especially for the social improvement. And we should have a closer look at the populations that are still at risk, poor populations, for example, in the north of Argentina, the Bolivian Chaco, and even in regions in Brazil that are supposedly without vectorial transmission. But we need to have a closer look at those populations in terms of screening and bringing patients to care. The second point, in my opinion, is to prepare the health systems for dealing with older patients with late sequelae of Chagas disease, especially heart failure. So the systems, they must be prepared for identifying this cause of heart disease and having resources to implement the guideline-driven therapies. We know that Brazil, in this aspect, has a relatively good situation in terms of availability of drugs and devices, but this is a very important problem for other locations. So second point is to prepare health system for this shift in the prevalence, age, and late sequelae. The third point, in my opinion, is about non-endemic countries. So people must discuss widely screening strategies, how to find the patients, and how to implement a systematic screening among at-risk populations, especially Latin American immigrants, so that we can change this scenario of low knowledge about the true burden of disease in these settings. And the last point that I would mention, it's to even in endemic and especially in endemic, but also in non-endemic countries, to find the ways to give access to care. So to have the patients screened and patients with to provide early diagnosis and treatment when appropriate for patients at risk. So we may take advantage of new technologies of artificial intelligence, EKG screening and echo screening to take this technology to the patients, to the populations that need, and bring them to the health system for specific care. So we have several actions to take from now. And as we say in Brazilian Portuguese, we only say hello to the ones that we know. So right now we know better when we are building a knowledge about Chagas disease. And in my biased opinion, I think that this publication today is a giant step, as well as all the studies related to the RAISE group of studies.
Oh, thank you, Bruno. We have only 2 minutes left, and I would like to give our final word. So first, the paper is available at the link for the full paper of the GBD on Chagas disease is available in the chat. Please read, comment, and say what you think about. We know a lot that there's a lot of uncertainty on these estimates, so we did our best to have the RAISE team, the IHME, to find the best sources to get the best model. But they are estimates, so other estimates can lead to different points. But what is very, very important is that we have a huge number of Chagas disease that is a lethal, lifelong condition living not only in Latin American endemic countries, but now in non-endemic high-income countries. They do not receive the adequate approach treatment, and they need to be seen. They need to be recognized as persons that they need health care. They need to be treated. This is a disease, is a social disease, a disease to people that live in poor places. So it's somehow a shame for the humanity that we still have such a huge number of Chagas disease patients. And this is something that will take some decades to finish, because if we interrupt completely in all places new cases of Chagas disease, we still take decades to treat these patients and to continue to have this condition. So we'd like to thank a lot the World Heart Federation with Novartis for taking the lead on these, and for the partnership with the Institute of Health Metrics and Evaluation. This was a very, very happy encounter, and we had a lot of work together. It was very, very good to work with different persons from different places in such an important topic. So for the funders, for all the involved, and for you from the audience that took 1 hour of your precious time to be with us. It was a pleasure to be here. Thank you so much.